Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, let's talk a little bit about the safe and smart reversal of anticoagulation and antiplatelet agents for 2022, because a lot's been changing and it's gotten complex, and I see people struggling, and I see people trying to figure out what the hell should we do, and in the midst of that confusion, the patient's bleed, especially if it's in their head, is getting worse and worse. Because the thing is, and we'll hit this again during the actual show, hematoma expansion for patients on anticoagulation really occurs in that first hour quite rapidly. And if you miss the boat on the first hour post bleed initiation, you're really not getting the full bang for the buck of the reversals. Now you're getting any potential deleterious sides without much benefit if you wait too long. So you need to have a plan in place ahead of time. You need all the logistics to make that plan work. And you really need everyone on board the team to know what that plan is. And so essentially that's what we'll talk about today. Before we get into it, Reanimate 8 tickets are on sale. If you've been waiting, we've been waiting because we've been canceled at all our other venues. Now we're at a hotel, so it's solid. They want the money. We want to give them the money, so it's all going to work out. September 7th and 8th, 2022, San Diego. Go to reanimateconference.com if you are interested in the best resuscitative ECMO course in the United States, in our humble opinion. All right, let's get to the show. Now, if you're on a computer and jump right over to EMCrit.org/319, you will see the EMCrit, ICH, and critical hemostasis algorithm. And we're going to go through that, and then we'll talk about some other topics. If you're not in front of a computer and you don't want to crash your car, I'm going to go through it piece by piece, so don't really worry. But you know what? Your leisure, check it out, because I think it's worth a download to have available for you, and maybe take it to your blood bank and talk to your neurocritical care people and the rest of your department and decide, hey, maybe this is how we want to do it, or feel free to adapt it as needed. All right, let's do warfarin first. Now, this is becoming less and less prevalent as the advantageous products like the Zabans come more and more to people's front of mind, but still plenty of people come in with warfarin-associated intracranial hemorrhage. I guess before we go for warfarin, what we should just say is, for me, this protocol is certainly for ICH, but it's also for life-threatening bleeds. And what life-threatening bleeds really are is a nebulous topic. Mike McGonigal of the Trauma Pro blog, he defines it as one of two things, either a physiologic or anatomic indication of life-threatening bleed, with the physiologic being bleeding that causes, he just says hemodynamic compromise. I think that's too low a bar. I would say severe hemodynamic compromise. And then anatomic, meaning you're bleeding into a body area that has a high likelihood of causing death or disability, which is why ICH is there, even though obviously that bleeding is not going to cause hemodynamic compromise from the amount of blood loss. Same thing for spinal cord or any location like a compartment syndrome type situation where any amount of blood is going to be deleterious. So that's who this algorithm is for. This is not for most of your GI bleeds. This is not for epistaxis, et cetera. This is for life-threatening bleeds and ICH. And the reason I separate out ICH is some of them aren't life-threatening, but they're really threatening to the patient's long-term outcomes. And you're never going to know how much of the continued hematoma expansion there's going to be at time zero. So if you don't reverse them and wait, you might have given up their chance to have a huge difference in their outcome. The thing with intracranial hemorrhage is even a tiny, like we're talking in the order of 1-digit mLs of blood, could be the difference between severe disability and a functional life. It's really small, the difference between they get out of the hospital walking and they're in a long-term care facility. And that's scary, and that really speaks to why it's so important to have all of this in place and not be inventing it as you go when a patient comes in with an intracranial hemorrhage on anticoagulation. Okay, so back to warfarin. My belief is every patient should just get empiric 1,500 units of Kcentra, which is a 4-factor PCC. Feel free to substitute whatever brand name you have in your country, like Berryplex, et cetera. So 4-factor non-activated prothrombin complex concentrate, 1,500 units empiric. And let's pretend first you don't have an INR. Well, then it's an easy one. Don't wait for the INR. Just give the 1,500 units of Kcentra empiric. And we're going to have a mixing video that's going to be coming out on how to do this rapidly. My belief is this needs to be in the department. Those 1,500 units, not more, not like the entire, equivalent of what it would give you 5,000 or 50 per kilo, which some patients may need. I would highly advise you have the 1,500 units boxes, which is 1,000 box and a 500 box, stocked in your ED. Now, this might be a big ask. It's worth it. Trust me. The amount of time it adds for pharmacy to get it to you, it's never going to get there in time. And it just adds so much complexity to an already fraught situation. So have it in your ED. Now, do you need it in ICU? Probably not, but you certainly need it in the ED, in my opinion. You need somewhere to lock it up. It doesn't need to be refrigerated, though oftentimes having a locked med fridge, this is the perfect place for it. You need some kind of way of tracking, or else the blood bank or pharmacy is going to be pissed. And you can make it all work. And if you have questions about that, about how we made it work in my previous institutions, feel free to drop me a line in the comments and I will happily answer. But I think you need those 1,500 units in your department. So you're going to give that empirically, have it mixed up quickly. It means, and I'll have the video, but this can't be a nursing thing only if your nurses are travelers or they're fluctuating or they're all new nurses because everyone quit because they don't want to be vaccinated for COVID, et cetera. Then you as the doc or the mid-level or whatever, clinical provider is handling this patient, you need to step up the game and be able to do it yourself. Now, if you're in a place lucky enough to have retention of your excellent resus nurses, then, you don't have to worry. And I will say, and I've mentioned this before, and I don't mean to piss anyone off, but if you are an ED pharmacist and you're like, they don't need that, I am here, I would say you're not performing your role in the best possible way. And my stance on this is unless you are guaranteeing an ED and critical care pharmacist 24 hours a day, 7 days a week, then what you should do in these circumstances is be the perfect farm supervisor for this to get mixed by one of the line clinicians, because then they are learning as you're making it go rapidly as opposed to you doing it yourself. I see a lot of the ED pharmacists, they are so efficient and so amazing, and all of a sudden they come to the bedside with the alteplase or the PCC, and I think that's a loss because it de-skills the bedside staff. So be the supervisor, teach them how to do it right. So you're going to get 1,500 units of Kcentra 4-factor PCC, and then 10 milligrams IV piggyback of vitamin K. So that's not rapid, but it's got to get in there because the PCC is very rapid reversal, but then it disappears as soon as the factors get metabolized. And if you want durable reversal, you need to have the vitamin K if they're on warfarin. Now, here's the key. We put that in over 10 minutes usually. That's off-label, so do whatever your institution tells you to do, but that's fine. Honestly, it's fine. You could obviously push the meds. I don't recommend doing that, but you could if you did it as a slow push. And then you check a INR 10 minutes after the Kcentra infusion is completed. And you will find in almost every case, my guess is that you hate that sound. And I apologize, but you don't have to hate that sound because you never have to hear that sound again because you could become an EMCrit member and therefore get the best critical care and resuscitation information to be able to take care of your patients. You do not have time to read 60 critical care resuscitation and EM journals each month and translate that information into usable logistical steps at the bedside. And that's, of course, what you get from EMCrit. So please consider joining. It's cheap and you could write it off and get it paid with your CME funds. So come on over to EMCrit.org, click the join button, and then you'll never hear that horrible, horrible sound again. All right. I can't wait to talk to you all again. Scott Weingart, EMCrit Podcast, saying bye-bye.